Thank you very much. Welcome to Grand Rounds this morning for orthopedics. Today I have the pleasure of introducing our father and son team, Heero Hacquebord and his son Jacques. The senior Hacquebord is a principal in App Consulting. It's an organization working with both service and manufacturing organizations to improve their performance and quality management. The senior Hacquebord holds degrees in mathematics, statistics, and an MBA, and is a protege of Dr. Deming. For those who don't know, Dr. Deming is the father of modern quality control, and he's also known for his work in post-war Japan for improving their performance and quality while simultaneously decreasing costs and increasing productivity. Deming's approach launched the Total Quality Management Movement and the PDCA, or Plan, Do, Check, Act cycle in management. The key principles of both Deming and Hacquebord are being applied to medicine and healthcare in our community. They include a focus on leadership, lean training, such as the Toyota approach, as you know, is being used at many institutions, process performance, statistical process control, and control charts to visually display process variation. Today, the father and son team will focus on healthcare metrics and the challenges of benchmarking and problems and opportunities with the current system. Their presentation is entitled, Do Quality Metrics Increase Costs and Undermine Performance? Heero and Jacques, welcome.
Good morning. Thank you for being here. I know for many of you this is maybe not the most interesting topic, but hopefully it'll pique your interest a little bit. This is something that we all deal with. So to begin with, for many of us, what exactly are quality metrics? Quality metrics, if you look on a lot of government sites, is defined as a means to quantify the quality of a selected aspect of care by comparing it to a criterion. There are many different types of quality measures. For instance, the access measure. This is how easily a patient can access the health care. Outcome measures. What is a patient's health status post-intervention compared to pre-intervention? The patient experience measure is pretty self-explanatory. How did the patient perceive their encounter with a healthcare system? And process measure of the entire system. And then a structure measure. A structure measure is, for instance, the nurse-to-patient ratio, something like that. So what should a quality metric be? How can you come up with a quality metric? First of all, very importantly, it has to be relevant, and it has to be influenced by the healthcare system. Secondly, it has to be scientifically sound. For instance, there has to be good, explicit data that supports this quality measure matters. And then it also has to be measurable. A lot of things are unmeasurable. So when you are picking a quality metric, you have to be able to measure it. Finally, also, it has to be feasible to collect this data. If the data collection is not feasible, it's going to be incredibly costly to go after this quality metric. I'd like to highlight here at Harborview the incredible measures that the Quality Improvement Program has done here, people like Patty Culver, and the mountains of data that is available, quality metric data that has been gathered. It's actually available on the HMC intranet, and it's open for all UW staff and faculty. It is truly incredible, the work that they've done there in gathering all this data. So now we know what quality metrics are. We know how they're used. We don't know how they're used yet, but you will soon. They're used for research, for one. They're used for decision-making for consumers, for the people that are purchasing the healthcare, for the patients. It also is involved with performance-based payment. Whether you like it or not, it's happened, it's going to happen more in the future. Based on quality metrics, if you have good quality outcomes or bad quality outcomes, your payment is going to be affected by that. And also accreditation of professionals or organizations. So the belief is that if you have decision-making, if you use quality metrics for decision-making, what you're ultimately doing is you're maximizing the net health benefit to the patients. Also, quality metrics are very much used for quality improvement. This is a huge aspect of how quality metrics are used. One form of quality improvement is through benchmarking. Benchmarking is used in essentially every other industry out there, and it's very, very commonly used in the healthcare industry as well. What is benchmarking? Benchmarking is that you measure and compare your own process to those best in class or the leaders in your industry. And then you identify what they did, and then you try to mimic them. You try to do the same thing so that you can have the same results. Returning to consumer decision making, this is a huge area for patients and for those purchasers of healthcare to try to figure out what's the right healthcare for them. So there are many different sites that try to facilitate consumer decision making. And I'm just going to briefly go through some of them because you might be aware of them, but your patients are definitely aware of them. The first one is Leapfrog. It's an independent national not-for-profit organization, and as you can read below, they strive to make giant leaps forward, and that's where the leapfrog comes from, I guess, in the safety, quality, and affordability of healthcare in the U.S., and this is by promoting transparency and value-based incentives and rewards. This is a diagram from the Leapfrog comparing some of the local hospitals. If you take a look here, this is their rating system, and it's important to note this is they're rating us on their Leapfrog standards. What exactly the standards are, where they're coming from, how they're defined, how they're measured is a little anomalous at times. If you look here, they're rating on some progress, substantial progress, and fully meet standards. This really begs the question, what's the difference between some progress and substantial progress? How do you quantify that? The hospital safety score is closely linked with the Leapfrog, and this is using one grade to evaluate or to rank or to rate a hospital. So based on one grade here of an A, a B, a C, you now know, supposedly, what the safety score of that hospital is. And this is based on a lot of data from the CDC, CMS, Leapfrog, AHRQ. Another one is the U.S. News and World Report, which sells a lot of magazines, rating the hospitals in the local area, 1 through however many there are, based on survival score, basically keeping patients alive. So how well you keep patients alive, it counts for about a third of your score. Reputation, patient safety score, and such. So if you look at Harborview is actually ranked 25th in the nation for the Department of Orthopedics. So this kind of leads the question, well, how does this help us? How does this help the patients? What does this exactly mean? What is our goal? What do we want to be? Is 25th good enough? Is number 1 where we want to be? What exactly does this ranking mean? And exactly how does this ranking help us? But also, how does it exactly help our patients? And then once again, you take a look, survival is better than expected. I'm not quite sure what better than expected survival means. A very, very commonly used evaluation form is the HCA-HPS. It's the Patient Satisfaction Surveys of inpatient stays. And it's a means to standardize survey instruments and data collection. And it measures the perspective of the patient on their hospital care. I know these are vertically aligned, so you can't quite read them, but this is some examples of communication with a nurse. And you have seen these surveys, I'm pretty sure, extensively, and it's based on never, almost never, sometimes, almost always, or always. Almost always, or sometimes, or a little bit more than sometimes, but not quite almost always. So you have to remember that these are incredibly subjective. So the Hospital Compare site is another site. This is through the government, and through there you can once again evaluate, compare the hospitals. And this is taken from their site. So looking at, this is what your patients are seeing, by the way. Just remember that. They'll go here and they can see, okay, look, Harborview, only 54% of the patients said they always received help as soon as they wanted. But that's compared to the national average of 64%. Does that mean that Harborview is a below average hospital? Because according to this, they are. But what does it mean to a patient that they always received help as soon as they wanted? And what kind of help were they wanting? I'm highlighting these points to let you know, just this is very, very subjective. Consumer reports, very commonly used for your patients as well. They also sell a lot of magazines. These are the criteria: safety score, patient outcomes, patient experience, hospital practices. Avoiding infections, avoiding readmissions is a big component of their safety score. We know what the infection rate is. We can calculate that. But how do we calculate those infections that we were able to avoid, or the readmissions that we were able to avoid? How do you know that you avoided something? But yet, that's a big part of the safety score. Another thing, their data is from public sources. Their scores are adjusted based on the health status of the patients to try to accommodate for the differences between Harborview or UW or Virginia Mason. And then they also state on their site that their data is scientifically based data on patient experiences and outcomes. I think that the use of the term scientific here is a very, very liberal use of the word scientific. And also, very important on their site, they say it helps you prevent, you being the patient, helps you prevent problems. And then they give the example, are you going to a hospital where you know that they have below average discharge planning? They said that if you as a patient, when you go there, you know that you need to be more cognizant of your discharge planning so that you can make sure that they do a good job. So, obtaining quality measures leads to improving performance, right? Well, we know that in between here, there's a lot going on. So obtaining quality measures, you have to analyze and interpret the data. Analyzing and interpret the data, you take the appropriate action, and that leads to improving performance, correct? Okay. So this is a very interesting article that Dr. Manna just made me aware of earlier this week, which I think fits in perfectly with what we're talking here today. And this is compliance with the Surgical Care Improvement Project. This is from hospitals in New York, and looking at their compliance with SCIP. And their compliance increased tremendously over a time period, almost to 100% with the SCIP protocol. And the SCIP protocol was set up to prevent reasonably preventable events, such as infections and venous thromboembolism events. And these hospitals followed their guidelines very strictly. But the interesting thing was that the infection rate actually didn't change with increasing compliance. It actually increased. The infection rate increased with increasing compliance with the SCIP protocol. Why would that be? So is that saying that increased SCIP compliance is actually causing worse outcomes? This is fascinating. Why is that? Well, if you take a look at this, obtaining quality measures, analyzing, taking appropriate action, and so forth, improving data, improving performance, it doesn't always work that way. And you have to, where did the SCIP protocol go wrong? Where in this process did it go wrong? So that leads to this. You obtain the quality measures, and my dad will talk about if you correctly analyze and interpret the data, and you take the inappropriate action, it actually leads to worsened performance. So that, I covered the easy part. My dad's going to cover the hard part.
Fabulous. Jacques did a great job, but what he also did was he was heaping it up a bit, and now I've got to avoid stepping into it. And that's not always that easy, but basically, when we look at the objectives here, we want consumer decisions. We want the consumers to make decisions as to where should they get care from. But it's futuristic, right? Consumers want to make decisions as to where they're going to get care from in the future, not in the past, right? I mean, they can talk about the past till the cows come home, but they're really interested in the future. We want to create performance in the future. Now, creating performance in the future is not the same as explaining performance from the past. They're two different things. We want to help prevent future problems. We cannot prevent the problems that we had in the past, right? We can explain why we had problems in the past, and we can theorize about what caused those problems in the past, but how does that help us prevent problems in the future? Selection for future professionals. What hospitals are we going to select for the future? In other words, the decisions we make is all related to the future. Now you have metrics, and you have a lot of metrics, and you have great metrics, and I've worked, and I still work in healthcare and industry and, airplane food, you name it. And in healthcare, probably has more metrics than anywhere else I've seen. And it's great. But do you know that the most important things that we need to manage and the most important decisions we need to make have no numbers and have no metrics? We cannot quantify them, And yet we have to make those decisions, and yet we have to manage those things. So why are metrics important? Various reasons. Metrics are very important because where we do have metrics and where the metrics do relate to the processes, it's important to understand how those processes behave in order to know what decisions to make. But most important, if I don't know how to manage and lead when I have metrics, in other words, if I take the inappropriate actions, as Jacques explained, and I analyze the data inappropriately with metrics, then I'm going to do the same when I don't have metrics. If I know how to analyze metrics, if I know how to manage with metrics, I will know how to lead when I don't have metrics. That's why it's very important to know what to do properly and appropriately when we have metrics. Now just notice, and this is extremely important, this is very, very important. This is actually touching on epistemological theory, but I don't want to go there. Whatever interpretations and action we take from metrics must impact the future. Now, metrics are past tense. How does explaining the past predict the future? I mean, if I were told that I'm above average in my infection rate, or I'm ranked on the top with a number of infections or whatever, if I'm told that, how does that help me make improvements for the future? How does that relate to the future? How does that help me predict what I need to do and what actions I need to take to impact the future? Most current methods of dealing with quality metrics do not predict what the future will be under different application strategies. Leadership is prediction. Medical practice is prediction. Current quality strategies are mostly looking in the rearview mirror, or standing under the horse's tail and trying to diagnose what the horse had for breakfast. And that's what we see happening in most instances. So we will discuss prevailing methods for quality metrics. We will discuss the real world of variation. I did some work a number of years ago for some hospitals in Iowa, in this particular county, and there were, I can't remember, 20 hospitals. And every month, they had published numbers from, I don't know, some government agency, the state. They had numbers that were published on the infection rates per hospital. So every hospital's infection rates were published. And those hospitals whose infection rates were above average had to please explain to the agency why they are above average and what they're going to do to get their rates below average. So every single hospital had an obligation to get their infection rates below average. So when will the performance be acceptable for that county? When all the hospitals are below average. Now, I mean, if you go and you tell that story to your kid, they're going to laugh their heads off, right? Now, how can you get all the hospitals below average? And how can you get your nosocomial infections below the industry average or the country average, the national average, or whatever the case may be? And how can everybody do that? We have to engage a consultant who can teach us how to calculate an average in a different way. Right? Because the way we calculate averages ensures for sure that about 50% are going to be above average and about 50% are going to be below average. So if any hospital or individual is above the average on some single event, you know what it says about their performance and about what's going to happen in the future? Zero. Zero. But if a hospital or an individual is above average 7 times in a row, then that means there's something wrong, there's something specific going on, and I better find out what it is and what can we do to rectify the situation. But you're going to have to wait a period, you're going to have to wait for 7 years or whatever. There are better methods than that. But you see what I'm trying to say, is that the real world of variation, we have to recognize it, we have to understand it. We have to know how to apply. What applications are we going to use in this real world? And we're going to talk about what can you do as an individual and what can you do as a hospital when somebody comes and asks you these kinds of questions. What is the appropriate answer? What is the appropriate action? And when you have some knowledge, you're able to not only improve the performance effectively, but you're also able to handle and deal with people that come and ask you questions and so on and so forth, the Joint Commission and so on and so forth. And when I work with hospitals, they always complain about the Joint Commission. And one of the hospitals that I'm working with, they've changed the way they analyze the metrics. And they said, oh, the Joint Commission, the Joint Commission. I says, well, wait. And the Joint Commission came, and the Joint Commission were ecstatic. They said, we just wish that all the hospitals would do this kind of thing. We just wish they would do that. They were ecstatic. So they're not a problem. They're not an issue. And, well, of course, what is the industry saying? We're going to just touch base with what Jacques spoke about. Now, the prevailing methods applied to quality metrics is, first of all, we have data collection, okay? And the data collection is mostly correct. We don't have an issue with data collection. People go, they collect the data's fine, not a problem. Then we manipulate the data. What do we mean by manipulating the data? Well, for instance, and I'm going to stick to infections or nosocomial infections because I was able to take a look at some of your data on that, and I don't have time to look at all the data. But if you look at infections, for instance, like in your case, the amount of nosocomial infections per month for the hospital, you have a certain number of inpatient hours that you experience that month, and you have a number of infections. And every month the inpatient hours differ. They're not the same. So what people do is they calculate some number per 1,000 inpatient hours. And there's a problem with that. There's a problem, and we'll talk about that. The numbers look fine, but when we start analyzing the numbers, you cannot analyze those numbers statistically because we don't have 1,000 inpatient hours every month. In the total hospital, it's a lot more than 1,000. And when you're looking at an individual ward, it's a lot less than 1,000. So just merely doing these calculations is a problem. And then, of course, we're going to talk about the data analysis. What action do we take? How do we analyze the data? And what happens often, not all hospitals do that, okay? My clients don't do this. They don't do that. But ranking, comparisons, rating, arranging things in order of magnitude, calling attention to high performers, low performers supposedly, benchmarking. Do you know that General Motors benchmarked Toyota? The Cadillac production system was an exact copy of the Toyota production system that they applied to the Lexus. And the taxpayer had to bail out General Motors. Now, how's that possible? How does that work? How does that work? And so we'll talk a little bit more about that. Incentives, rewards, punishments, right? If we punish somebody, they're going to perform better. If we reward somebody, then they will perform even better, and those people that were not rewarded, they will now start performing. And we've applied these techniques for at least as long as I can remember, which is at least 40 years. And they haven't worked yet. And my question is, when are they going to start working? Data manipulation, data calculation. If your inpatient days are greater than 1,000, then obviously infections per 1,000 inpatient days is an average, correct? It's an average. Now, when you calculate an average and you compare these averages with one another, you have to take the sample sizes from which the averages were calculated in consideration. Otherwise, you cannot calculate the average. It's like somebody doing a survey in Seattle, and they say, I want to see whether there's a change in the height of men over the age of 30 in Seattle. And they go out and they take a sample of 5,000 men, and they calculate the average height. And the next time they go and they take a sample of 50 men, and they calculate the average, and now the average height is much greater, and they say, wow, the men in Seattle have grown taller. You can't do those things. You have to take those sample sizes into consideration. If the inpatient days are smaller than 1,000, so we had 500 inpatient days, and we had one infection, and now we say, oh, it's 2 infections per 1,000. How can you say that? We did not have 1,000 inpatient days. But we are now making an estimate, an assumption, that if there was one for 500, there'll be 2 in 1,000. How scientific is that? You know, Jacques referred to some crazy ways they do patient satisfaction surveys, and I can tell you a lot of stories about that as well, because I've done research on patient satisfaction surveys. And the subjective way in which patients give you feedback on their experiences. Now, if a physician had to use those kinds of subjective methods in gathering the vital statistics of patients, what do you think would happen to the patients? I think they die like flies, right? Just imagine. You don't have proper instrumentation in doing blood tests. You don't have proper instrumentation in doing blood pressure. You just make a subjective evaluation of what you think that patient's blood pressure is, or a subjective evaluation of what you think that patient's blood contents are, and so on. We'll never dare that in medical practice. But patient satisfaction surveys, choosing hospitals, choosing physicians, no problem, no problem. We'll never do it to the patient, but to hospitals, to individuals, no problem. We need to calculate a rate that applies to the actual days, the actual inpatient days. And we're going to show you, we're not going to show you how it's done. I mean, that's beyond the scope of this. Rating, benchmarking, exhortation. How does ranking hospitals improve performance? Here's a hospital that was ranked last month. Now I draw their attention to that. I exhort them. I tell them that I'm going to take away your accreditation. I'm going to do this. How does that help them improve performance? People generally say, well, that motivates them to improve performance. That activates them to improve their performance. So what you're telling me is that generally speaking, they don't want to improve their performance. So generally speaking, the people in that hospital don't really want to improve performance. They're not interested in improving performance. But I've got to apply some extrinsic force, and then and only then they will improve their performance. And that's what people tell me. They say, you know, those guys out there, those people out there, they're not interested in improving their performance. My response is, are you talking about them or are you talking about yourself? No, I'm not like that. They're like that, not me. You see the problem? How does benchmarking improve performance? I was doing work with a company. This company manufactures a lot of things, and also medical devices. And I was looking at some data on their safety. And there was a period of time where their safety was not good at all. And then there was a tremendous improvement in their safety. And then after that, a period of time where the safety was poor again. And I said, but what happened? Your safety was lousy, then it got better, and now it's not good anymore. What happened? And they said, wow, the safety manager said, let me tell you the story. He said, in this period when our safety wasn't good, we went out and benchmarked a company. And they are the best in class in the United States of America with respect to safety and industry. We benchmarked them. And we found out that what they do is they pay a bonus. They pay a safety bonus depending on the number of accidents. And so we introduced a bonus. And we paid a safety bonus, and our performance was just fabulous. And I said, okay, good. What happened then? They said, well, what happened in that organization, about a year down the road, they got audited by OSHA. OSHA came in and found out that they were not reporting their accidents. And so OSHA fined them $5 million. And these people got the fright of their lives. They eliminated the bonus, and their performance was not good at all. Their safety performance was lousy. So they said, we're going to have to find and benchmark somebody. So guess what? They looked us up, and they found our performance was great, and they came to us. I mean, 3 years later, there were different staff that came and benchmarked us. And they said, what do you guys do, and how do you get? And we said, well, we pay this bonus. And they said, oh, don't do that. We did that, and we got fined $5 million. So we got the fright of our lives. We eliminated the bonus, and our safety is back to where it used to be in the past. And that's what happens with benchmarking. Okay, if you're going to benchmark Honda Motor Company, which is a great company, they manufacture fabulous cars, a fabulous company. You're going to benchmark Honda, what are you going to find? You're going to find that the people in the shop floor wear uniforms, and that nobody is allowed to blame a worker when something goes wrong. So you come back and you implement that in your company, and you know what you're going to see? No change. Because you don't understand their philosophy, you don't understand their theory, you don't understand why they do that. So benchmarking without knowledge is just off to the Milky Way, may I say. What causes good or poor performance? Where does performance come from? Does performance come from changing the people, or does performance come from changing the system? And if both, how much percent of the performance comes from the system, and how much percent of the performance comes from people? Now, here's some data. Here's the data that I saw, and it's fabulous data. We have the total inpatient days. There's the inpatient days, actual days, for the total hospital, for your hospital, number of nosocomial infections. Fabulous data, great data, source data. There's nothing better than source data. Because when you have source data, you can really start applying appropriate analysis. This is the rate. Now, this rate is calculated. It's a normalized rate. It's a statistically adjusted rate based on those actual inpatient days. Don't get hung up and say where this comes from. This comes from a statistical calculation. It's easy. That's all there is to it. If you have data that is very important data, and the generation of the data comes from the application of pretty sophisticated scientific practices, then you would expect the analysis of that data also to be subject to pretty scientific analysis and not just grade 5 mathematics. So don't worry about this. But look at this data. You see there's a 13, there's a 6, there's a 15, there's a 6. Why these differences? Where are those differences coming from? Why is there a difference? I mean, if we did a perfect job, there shouldn't be any variation, right? Everything should be perfect. Should be the same. Have you ever seen data where there's zero variation? When you see that, you get concerned. So there is variation. Why this variation? It could be that, I don't know. I don't know your situation. I don't know. But, you know, is the patient population the same from month to month? The patient population is different, right? Different patients react different to treatment. Is that correct? Some patients are more robust than other patients. Some patients are more immune to infections than other patients. Is that correct? You must correct me here, because I'm not a physician. And how about the environment? How about the temperatures? How about the condition of the patient when they came in? I mean, there are many factors which affect your infection rate, which are beyond the scope and control of any individual person or caregiver. Is that correct? So how do we know when these variations over here are due to what we call the system, the many things that cause variation, or are due to some specific event that happened, some undesirable event that may have taken place that particular month? We have two sources of variation. This is fundamental theory invented by Dr. Walter Shewhart in the 1920s. The Japanese were taught this theory, and after the Second World War, this theory in the United States of America just went up in smoke. And it was replaced by all these other things that we're pretty much doing today, most of which. In any case, there are two sources of variation: common cause. Common cause variation enables us to predict what the variation is going to be in the future. We cannot predict the exact number, but we can predict an upper limit and a lower limit. We can predict the amount of variability. It's always present. It's built into the system. You cannot eliminate it. We can only reduce it. Common cause doesn't mean to say it's acceptable. It just means that it's in system. It's built in the system. And there are many of them, and they're common to all the values. The high values and the low values are there for the same reason. And then you have a special cause. Unpredictable. You don't know when it's going to happen. You don't know where it's going to happen. You don't know to whom it's going to happen. And you don't know what the effect is going to be. We need to eliminate them. When we see them and we find them, we need to eliminate them if they are undesirable. If it's a desirable special cause, we need to emulate it. And special causes will increase total variability. Do we have special causes in this world? Yes, we have special causes. There's only one or a couple of them. Most of the time, you will have common causes only. Common causes will always exist. The system is always there. Most of the time, you won't have special causes. But when you have a special cause, we have to deal with it appropriately. So, this is basically a summary of the way we're supposed to act if we want to impact the future. We have common causes, and we may have one or more special causes in addition to that, and we can either change or improve our system, Or we can find out what happened, why did this happen, where did this happen, with whom did this happen, and what are we going to do to make sure this doesn't happen again. Those are the only two actions that we can take in any given situation. I know of no other action other than let's do nothing. And sometimes it's better to do nothing than to do something, because if I have common causes and I want to find out what happened and make sure it doesn't happen again, I'm going to tamper, I'm going to knee-jerk, and I'm going to make things worse and increase variation and increase costs. So if I go and benchmark another organization who has some number that looks better than my number, or some best-in-class number, and that organization is not a special cause on the good side, and I wouldn't know that unless I analyze the data appropriately. I'm going to show you how to analyze that data. I'm going to show you the consequence of analyzing the data. And I go and I benchmark a company whose performance in comparison to my performance is just common cause. Like, for instance, I'm going to benchmark this company, or in this case, this month, but that difference is only common cause variation. That benchmark results in tampering. And all I'm doing is I'm tampering and I'm spending a fortune. I have read things on benchmarking. I have seen benchmarking, but I have not found or heard that type of strategy anywhere. Actually, my clients don't benchmark, and they're happy for that, and so am I. But I'm not saying don't benchmark, but benchmarking without knowledge, without this theory, it's not going to get us there. And if I have a special cause and I go and change or improve the system, I'm taking inappropriate action. So there's only two cells here where I take appropriate action. And I've done many, many studies in different countries. And in the Western world, it comes out that we tamper about 70% of the time. In Japan, where I did my studies, tampering was about 50% of the time. So they took the appropriate action 50% of the time. And I told the Japanese, well, why waste your time taking decisions? Just flip a coin. If it's heads, you take this decision. If it's tails, then you take the other decision. They just looked at me and smiled at me like I'm from Mars. So we've got to distinguish between common and special causes. We've got to take the appropriate action. The control chart is the appropriate tool. This is a control chart of your data, right, which is the infection rate. So we have here the first column. You don't have to worry. The first one is the month. Then we have the total inpatient days. Very important. Those numbers are very important. And then the number of nosocomial infections, and then the adjusted occurrence, the adjusted infection based on your actual inpatient days. And when you look at this chart, the chart is plotted. You see an upper red line. That red line is a calculated control limit. This red line is a calculated control limit. It's not what we want. It's not what we like. It's not what the Joint Commission asks us to do. It's not some kind of a goal. I believe you have a goal for infection rate. Is that correct? 0.86? So I'm a patient and I walk into your hospital and I find out that you have a goal for an infection rate of 0.86. I'm like, oh, no, man, I don't want to go there. These guys like infections. Now, I know what you say, not you maybe, but people outside this room, they'd say, yeah, but we want 0 infections. But if we made it 0, it's unrealistic. It's not a realistic goal. You have to give people a realistic goal. And 0.86 is realistic. What does that mean? That means we have a method for accomplishing a goal of 0.86, and when they've achieved that, then we make it 0.5. Now we have a method for 0.5. The method does not come from the goal. The method comes from knowledge. A goal does not provide a method. So what is the goal? The goal is continual reduction of nosocomial infections. That's my goal. Continual reduction. And plot the chart and see if it's going down. In this case, it's not going anywhere. It's not going down. Your nosocomial infections are predictable. And from this, you can see that you can get anything, any month in the future. As long as you don't change your system, any month you can get up to about like 20, a rate from 20, anything from about like 0.4 to 20. And you say, oh, that's awful. Well, I don't know whether it's awful or not. You say, that's a tremendous amount of variability. Yeah. Your system is giving you that variation. You don't like it? You better go work in the system. Because if you go work on people, you know what's going to happen? No change. Continual performance of the past, and people are going to get frustrated and irritated and mad. That's what this chart does. So basically you say, how should we analyze our metrics? We should put our metrics in a control chart. You say, is there any other statistical way we should analyze our metrics? And I'm saying, no. Control chart. There are different control charts for different kind of metrics, but that's it. Whether I'm comparing hospitals, whether I'm looking at monthly performance, control chart, that's it. It's an analytical, statistical method to enable me to predict the future and to identify whether I have any special causes. And we want to know what action to take, and this particular chart will tell you exactly what action to take here. It says you have common cause, variation only, etc., etc. So if you don't like performance, you must change the system to focus on any individual person, event, or cause will be the inappropriate action, will lead to tampering and increased cost. It tells you what to do. It's actually much easier than ranking and rating. You just plug the data in and you hit a button, and you just read the rest. Reduces costs in collecting and analyzing metrics and helps me make appropriate decisions. How about, let's take a quick look here and we'll end. If I assumed that this was the surgical site infection rate for these doctors, what action would you suggest we should take? What action should we take? Don't you think that if we had to get the top intelligentsia in the medical field in this country, including the government and including everybody who's running for president, in a room with all their aides and ask them what action we should take, and what are they going to say? Amen. Oh, Dr. Andy's a problem, right? Okay, so let's get Dr. Andy out of here. Then there's Dr. Ann, out of here. Dr. Jessica, out of here. Well, we get rid of all our docs. No problem. Problem solved. How do we know that Dr. Andy is a special cause? The education system in this country and in other countries in the Western world and in the Eastern world, pretty much for that matter, do not teach this theory. That's why you don't see it. You may have seen it because somebody told you, but you're going to go to college, you may see it, but it's going to be kind of slipped in there. So the appropriate action is to plot the chart. And interesting enough, everybody's inside the control. There's nothing to suggest that Dr. Andy is a problem in relation to Dr. John. Dr. Andy is high for the same reason Dr. John is low, because it's the system that threw out those numbers. You don't like that performance? Improve the system. Somebody asks you a question about metrics and performance. Your response is, are you talking about special causes or common causes in this data you're showing me, sir? That person cannot give you a definitive answer. Then you cannot respond with a definitive answer either. End of conversation. That person responds with a definitive answer, yes, this is a common cause, or yes, we have special causes. Then you ask to see the control chart. Were you shown a control chart that was correct? No. Can you obtain one? No, I cannot obtain one. Then you find somebody who can help you and help the questionnaire create their control charts so that you can go through this loop and you can answer yes to this control chart, and then you take the appropriate action. That's what you got to do. When asked that question, get them through this to the end. It's the only way we're going to get to the appropriate action. Anything else is going to lead to tampering. We may take the right action. We may be lucky. Who knows? What is the industry saying? Benchmark best practices, rank performance, patient satisfaction surveys. My last story, and then I'm done. I was working with patient satisfaction survey people in a hospital. And there's a crowd that does the patient satisfaction survey for them. And I'm not going to tell you where they're from because then you know exactly who I'm talking about. And I looked at the patient satisfaction survey numbers and we plotted them in a chart. And we compared them to the control limits. And the control limits were there. And the percentage patients that were satisfied was varying from month to month, like there was virtually no variation. And I said, these numbers are not right. They're not true. Because the numbers do not match the control limits. Something is wrong here. Everybody argued like crazy. They'll take me to court and I don't know what. I said, well, I'm going to tell you right now. A year later, with that same people, we spoke to the people who do the patient satisfaction surveys on the telephone. There were some questions they had. And this person said, the people that we employ who do the patient satisfaction surveys, who call the patients on the telephone, they are paid piecework. They are paid an incentive based on how many phone calls they make. Aha. So what happens when somebody is paid incentive pay and he's working at 10 o'clock at night and they're like, I want to go home? What do they do when they paid incentive pay, piecework pay? Frederick Taylor found that out, and we found that out a long time away in the 1800s and 1900s in this country, in the industry. You know what they do? They just create the numbers. They create the numbers. They just fudge the figures. And the only people that know how to fudge figures in such a way that I cannot catch them on a statistical analysis are people that understand the statistical theory the way I do. Anybody who doesn't understand the way I do, I'll catch them. Because they cannot fudge figures according to a distribution. There was a patient said, and these people pay a fortune for these surveys, and patients choose hospitals on these numbers, and so we go. So the industry has a lot to learn, unfortunately. As I said, we've been doing these things for 30 years, and my clients tell me that healthcare costs are increasing, and patients are, satisfied, dissatisfied, no difference in the past, but healthcare costs are increasing like crazy. And I'm like, if it works, when is it going to start working? Do metrics help? Yes, if we use the appropriate methods. Are they going to increase costs and undermine performance? Absolutely so, if we use the incorrect, inappropriate methods. Thank you very much.
Thank you very much. A very thought-provoking presentation. And it brings up at least a couple questions that I have, but I'll see if there are any in the audience. Please go to the microphones. If not, let me ask Heero a couple of questions. The government is focused on what are called never events, for which they won't pay hospitals for caring patients who have one of these never events. An example is deep vein thrombosis. And as most physicians know, most of these are caused by common causes, yet their policy is essentially that they expect zero. So how should physicians and healthcare organizations approach the government in terms of having them help us manage these never events?
It's a great question. If I were to be politically incorrect, I'd say the problem is government's involved with healthcare. It's not their job. But I have to be politically correct, of course. But the point is this, that you're in the situation, you have to do something about it. And I would plot a control chart. I will get my data on a control chart on these never events, which means they are never, never, right? Okay, did I get that right? They're yes. Never, never. And I would plot a control chart on these never, never events. And I'd show this control chart to the people, the government agencies, who they are, and I'd say, well, this is where my never, never performance is at. And I know you want it to be zero, and I agree with you, it should be zero. So how do you suggest we get it to zero? We will continually work towards zero. But if you quit paying us, how is this going to become zero? We're just going to refuse to treat patients. Well, I'm not saying you should say that, but I mean, refuse to treat patients who can become such a statistic. Please show me, please ask me, please help me to understand, how would I get this to zero? If you did not pay me, how would I get this to zero? I was working for a company where the government, it's a government contract, and the government said that if you manufacture so many units, you do this, we'll pay you a $3 million bonus. And the CEO said, I don't need a bonus, because I don't need a bonus to help me produce so many units. The bonus will not increase my production rate. I refuse a bonus. I don't want the bonus. The government financial department didn't know how to deal with that answer because they had to pay the bonus and they had a system set up to pay these bonuses. And everybody else in the industry was accepting these bonuses except this person. And they didn't know how to deal with that situation. So you have to create an anomaly for them. You see what I'm trying to say? In a nice way, an anomaly for them. I don't know the details, but that's part of the stuff I do.
Another question is, there's been a focus on, obviously, benchmarking, as you suggest, in healthcare. And physicians typically claim that their patients are sicker than their colleagues. So that has shifted the focus a little bit towards risk adjustment, especially weighting comorbidities to substantiate that one's hospital's patients or one's patients might be sicker than a comparison. What can you tell us about risk adjustment and how that might affect patient access?
Well, you're getting a little technical for me here, but again, without the metrics, without the appropriate metrics, and without analyzing those metrics on a control chart, you haven't got an argument. Because your argument may be correct in saying my patient population is different than yours and this and that, but it gets into a verbal confrontation. And with the control chart, you can say, well, look, if you look at the control chart, here's a special cause. And we're going to find out what has happened, and we can go and benchmark this or whatever. But in this particular case, you're asking me to benchmark. We're all common causes, so you want me to benchmark random variation? Is that what you're asking me to do? There's no substitute for knowledge. Stupidity won't suffice. So you have to get that knowledge base. You have to be ahead of the government. You have to be ahead of the Joint Commission. You have to be ahead of your competitors. You just have to be ahead of everybody else. You can't play in the same field that they're playing. You have to get ahead of them.
Well, thank you very much, Jacques and Heero, for your presentation. Appreciate it.